Good afternoon, everyone, and welcome to today's webinar, Ready, Set, Go for the No Surprises Act, which will be presented by PYA. I'm Rodney Adams, Vice President of Research and Reimbursement for the Tennessee Hospital Association. I'm joined today by my colleague, Amanda Newell, Vice President of Financial Policy for THA, and Kathleen Caluette from the Tennessee Medical Association.
Thank you, Rodney. And again, I wanted to thank everyone for their participation in today's program. As we enter the final month of preparations for the start of this new law, we wanted to offer a final summary of the bill and what you need to know to be prepared for January 1st. THA and the Tennessee and TMA are happy to be able to partner to offer this timely educational session.
Thank you, Kathleen. And yes, we are excited to be able to partner with you and TMA today. Just a couple of housekeeping items for everyone. I would like to remind you that all attendees have been placed in a listen-only mode. We will be taking questions throughout the presentation, so please enter your questions in the question or chat function at any time during the presentation. We'll monitor these questions and address them at the end of the presentation. Amanda, would you like to introduce our speakers today?
Yeah, thanks, Rodney. Also mention the slides that PYA will be going over are available for download in the handout section, so you guys can have that as we go through it as well. But yeah, to introduce our speakers, we're excited to have Marty Ross and Kathy Reep with us today. Marty Ross is the Office Managing Principal in the Kansas City office, and she is also the Director for their Center for Rural Health Advancement. She's had a successful 2-decade career as a healthcare, transactional, and regulatory attorney, and now she serves as an advisor to providers navigating the expanding maze of healthcare regulations. Her deep and wide understanding of the new payment and delivery systems and public payer initiatives is a valuable resource for our providers that are definitely seeking to strategically position their organizations for the future. And with her, we also have Kathy Reep, Senior Manager with PYA. Kathy has more than 3 decades of leadership experience in the healthcare industry. Her hospital setting experience is in compliance, financial advisory, reimbursement, and managed care. Prior to joining PYA, Kathy served as the Vice President of Financial Services with the Florida Hospital Association, and she's held long-time hospital positions with roles in patients' business, internal audit, systems management, diagnostic-related group management, and as a reimbursement director. So Marty and Kathy, thank you for joining us today, and I'll turn it over to you guys.
Thank you, Amanda. Good afternoon, everyone. Pleasure to be here with you today talking about somewhat unpleasant topic of the No Surprises Act. As you've probably heard way too many times, this new law goes into effect on January 1st of 2022. And if it seems a bit of a surprise how quickly this has happened, it is because we are dealing with 2 sets of implementing regulations that were published first in July and the second in October of this year. CMS published both as, not just CMS, all of the agencies that are involved in this process, which include CMS, the Office of Personnel Management, Department of Labor, Department of Treasury, because we're talking about regulation of both healthcare providers and health plans, very broad regulatory responsibilities. But the agencies together published these as interim final rules. And so we did not have the usual process of notice of proposed rulemaking. Instead, this happened very quickly, in part because the legislation that created the No Surprises Act was the Consolidated Appropriations Act of 2020, that monstrous piece of legislation that passed in late December of last year that has the distinction of being the single largest piece of legislation Congress has ever enacted. And it included these provisions we're going to drill down on under the No Surprises Act. And we'll refer to it by its new acronym, the NSA. The NSA has 2 purposes and thus 2 distinct regulatory structures that we as providers have to get our arms around here in short order. The first is to prohibit surprise billing and replace it with a new payment methodology. And we use the term surprise billing to refer to an episode where a patient, through no fault of their own, received services from an out-of-network provider. So this isn't balance billing, because balance billing is very broad. It can happen in a number of circumstances where a patient affirmatively chooses to go to an out-of-network provider. These rules around surprise billing are limited to those circumstances where patient ends up receiving services from an out-of-network provider and it's not due to anything they did, in short. Secondly, the second purpose behind this legislation was to provide self-pay patients with good faith estimates of charges, so that these self-pay patients are making decisions with necessary information regarding the costs that they will incur for services that are being scheduled. So we're going to talk about each set of regulations and requirements around these two purposes separately. But that's the first key, again, to getting your hands around the No Surprises Act, is really appreciating these are two distinct sets of requirements. They apply they have different scope, they apply to different types of patients, they impact providers differently. So let's start with surprise billing. And here, the application of these rules include healthcare entities and health insurance issuers and health plans. So let's start first with healthcare entities. Here we're dealing with facilities. The term used in the statute is facilities, which refers specifically to hospitals, critical access hospitals, freestanding emergency departments, and ambulatory surgery centers. It does not include urgent care centers. These rules also apply to providers that furnish services to patients in facilities. This would not apply, these rules do not apply to physicians not providing services at facilities. The particular scope of the No Surprises Act is those services that are furnished in facilities, on the assumption that if a patient elects to go to a physician's office, that they know that physician is out of network. And so we don't have the underlying purpose being called into play because we only concern ourselves with surprise billing when the patient didn't know they were going to be receiving services or couldn't control the fact they were receiving services from an out-of-network provider.
Marty, if I can jump in just for a minute.
Please.
Under the facilities, you did mention that it doesn't apply to urgent care facilities, and that is true right now, although they are evaluating that. But we seem to have missed from our list. It's not something that we think of as a facility, but the law is also applicable to air ambulance, not ground ambulance, at least not at this time, but it is applicable to air ambulance as well.
Right. And we mentioned previously the two interim final rules, the July and October rule. Just to make it more interesting, in the middle, there was also in September, they published a proposed rule. That proposed rule in its scope included the enforcement provisions for this legislation, for these regulations, as well as specific requirements on air ambulances, including a whole range of data collection mandates. And that's a proposed rule. We'll have to wait for it to go through the notice and comment period and then be published in its final version. So to some degree, yes, definitely air ambulances are in play here. It is probably further down the road until they're truly at the table enjoying the feast that is the NSA. On the side of health insurance issuers and health plans, we're going to include group coverage, so that's both insured and self-insured plans, ERISA plans, non-federal government plans, church plans, and traditional indemnity plans. We're also going to cover individual coverage, whether that's an exchange or a non-exchange plan or student health insurance. One of the reasons that federal legislation was needed to address this issue of surprise billing was while we had a number of states that had adopted legislation to address this issue, the state regulation could not reach ERISA plans because those are regulated at the federal level under the Internal Revenue Code. We also had the issue of folks moving across state lines and the question of a state regulating a plan that's based in a different state. So that was the driver behind a federal legislation to address these issues. You folks in Tennessee are lucky because you did not have an existing state law that you're going to have to rationalize with the new federal rules. There are many states that, again, that still have regulations on the book now, and there will be some figuring out which rules apply when in those states. But for folks in Tennessee, that's not one additional worry for you. The surprise billing rules do not apply to Medicare Advantage plans or Medicaid managed care. Those are separate rules that govern surprise billing for those plans, nor do they apply to health reimbursement arrangements, health sharing ministries, or short-term limited duration insurance or retiree-only plans. One of the first requirements we're going to deal with under the surprise billing rules are the patient notice requirements. Both facilities and providers that furnish services in facilities are going to be required to provide a notice to patients of NSA protections. And that notice is delivered in 3 ways. You have to post the notice prominently at your physical location. So think of where you have your HIPAA notice of privacy practices now. It will now have a neighbor, which will be the NSA surprise billing notice. You're going to post it on your website, and specifically the regulations require that it be either on the homepage of your website or that there be a direct link from the homepage to the notice. And then third, you'll be required to give the notice to each insured individual other than Medicare and Medicaid to whom services are provided at the facility in the manner that's requested by the patient, no later than the time at which payment is sought from the patient. This obviously creates some interesting issues around who gives the notice to the patient, because certainly the facility, which has direct contact with the patient, would deliver the notice. But think of all the providers that furnish services in the facility: the radiologists, the anesthesiologists, the pathologists, the intensivists, the hospitalists. Are we going to require all of those providers to be delivering notices to the patients for whom they would provide services in the facility? The answer is yes, with an exception. The regulations permit a facility to enter into a written agreement with the providers who furnish services at the facility that permits those providers to rely on the facility's notice. So on the work to be accomplished here in December, before this go live date of January 1, as you're working through the processes for delivering this notice, high on that list should be communications between the facility and members of its medical staff and other providers to get these written agreements in place so we can avoid overwhelming patients with notices or simply just creating a great deal of administrative confusion otherwise. See here on the screen, this is the model notice that CMS has provided. They are clear that it should be 1 page, front and back. It has to be at least 12-point font. This is, again, a template. You're not required to use this notice, although use of this notice constitutes a good faith effort of compliance, according to CMS. You see on the left-hand bottom the link to the website where you can find this notice. It actually takes you to a zip file, and you have to open the zip file. But also on the right-hand side, you'll see in red a phone number and a website. If you look at the notice itself above, you see the language, if you believe you've been wrongly billed, you may contact, and then there's a bracket. The bracket should be filled in with this phone number, according to CMS. They published a memo in late October providing this information to include in the model notice. And then you see that last paragraph says, visit bracket website for more information. And there is the website to insert into your notice. So again, short order here on this work. Expectation that the notice is on your website, posted physically at your facility, and being delivered to patients starting on January 1. Kathy, over to you then.
Thanks. Let me talk a little bit about when this No Surprises Act, this component applies. So first of all, we're going to look at emergency services. In the case of emergency services, whether the facility or the provider is participating in the Medicare, participating with the plan or not, the law is applicable. So in the case of emergency services, assume that it is always applicable whether or not the provider or the facility is in network. If the services are, if the provider, when we start looking at what are emergency services, there are some good things that I think came about in the final rule on this because of the way that they have defined emergency services. First of all, it is definitely prudent layperson, and it is based upon the what the patient, when they presented, and whether or not they believed it was an emergency situation, not a final diagnosis or anything like that. It is strictly based upon the determination of the patient when they presented as to whether or not it was appropriate to go to an emergency department. There were some payers who earlier this year had addressed the fact that they were going to be using artificial intelligence to look at final diagnoses for emergency room claims and to deny services if they did not meet a true emergency. This is not something that we will be that the payers will be allowed to do. Secondly, and again, a very positive, we've had scenarios in the past where a patient presented to the emergency room, needed to be admitted as an inpatient, needed to go to observation, or actually even needed surgery. And what happened was the payer would deny the care, saying that the services could have been provided at an in-network facility if the patient had been transferred. Under the new law, it is the treating physician and his or her opinion as to whether or not the patient can be safely transported to another facility that will define the end of the emergency period. If the treating physician believes the patient needs to be admitted, could not leave and go to another facility in a non-medical means of transport, then the emergency period continues and the care is to be covered by the payer under the new guidance. I think that is very, very positive for providers, and both for the hospitals and the physicians in terms of determining when the emergency period ends. It is going to be left to the treating physician and using the criteria of whether or not the patient can leave using non-medical transport. And essentially under the law, the out-of-network, the facility, neither the facility nor the providers are going to be able to balance bill the patient in the case of an emergency. So let's go on and look at what happens in the case of non-emergency services. Next slide. Okay, if the facility itself is out of network, then the law is not applicable. So that's the one thing we've got to start with. The patient presents in a non-emergent situation to a facility, but the facility is out of network. The law is not applicable to the facility. The law is not applicable to the providers who are providing services at that facility. However, if the facility itself is in network, then the law becomes applicable to the practitioners or providers who are providing services at that facility. Many instances you have a facility who is in network with a payer, but the physician is not. So now the law comes into play. In the case of a provider or some providers who are out of network, even though the facility is in network, that provider would be able to balance bill the patient in a non-emergent situation with consent. We'll talk about the actual consent in just a minute, but recognize that with a consent from the patient prior to services being rendered, you could balance bill the patient. However, there are certain professionals who are not going to be able to balance bill even with consent. They cannot get a consent from the patient. That's going to be your emergency room physicians, your anesthesiologists, pathologists, radiologists, neonatologists, your assistant surgeons, hospitalists, and intensivists. All are listed in the law in terms of those who cannot balance bill a patient, nor can they get consent to balance bill the patient. In addition, if there are diagnostic services that are required to diagnose or to treat that patient, those cannot be balanced billed. And as has been the case in the past, if the services that are ultimately provided are in response to an unforeseen need, those are not going to be able to be balance billed. Think about the issue of a different, of another provider having to be called in during a surgery. That physician is not going to be able to balance bill if he is out of network. And if there are no in-network providers who can furnish the service at the facility, then the provider who is furnishing the services is also going to be precluded from being able to balance bill. Marty and I talked about this for a while as we've been doing these presentations. And when we start looking at, okay, so who can get a consent to balance bill? In most instances, we're looking at probably the surgeon, unless it is one of those surgeons who's called in for that unforeseen medical need. But in the case of a scheduled surgery, you're not going to be, your surgeon is going to be able to balance bill, but not your assistant surgeon. And in the case of a consulting physician, I think it's really going to depend upon whether there was the opportunity for advance notice to the patient and the opportunity to consent. Marty? This link.
No, go ahead.
Okay, this link gives you, or this slide gives you the link to the standard notice and consent document that has been designed and made available by CMS and the other parties. Recognize that there's considerable detail that is required on this consent in terms of the estimate of the charges that are going to be involved in the care of the patient. And there are strict regulations related to the timing of this notice. Now, we're going to be talking about timing of the good faith estimate in a few minutes. So I want to make sure that you're clear that these are two different timing standards that we have to look at. The first one that we are looking at is as it relates to the consent for to be balanced billed. First of all, if the services are scheduled at least 72 hours in advance, then you're going to have to provide notice 72 hours in advance. If the service is scheduled less than 72 hours in advance, you've got to provide it the day of the appointment, but not less than 3 hours prior to service. Now, I think that's where it gets very tricky, because if you are perhaps doing a procedure in your office as a physician and you are out or you're doing the procedure in a clinic and you are out of network, although the clinic is in network, where's the patient waiting for 3 hours prior to being able to have the service provided once they've been given and they have signed the consent? I think it's very awkward. I think the wording for that or the timing for that is very hard to deal with. The idea of a same-day service, having the patient wait for 3 hours. Your health plan you're going to be required to give the health plan a copy of that signed consent. There is going to be a requirement ultimately that you notify them through your claim, and then also that you send them a copy of that signed consent. I think the issue right now is there is not a means to notify them. There is not a communications on the bill or on the claim. Ultimately, I think you're going to see the National Uniform Billing Committee and the National Uniform Claims Committee identify some codes that would go on claims to show that you do have a signed consent, and then there would be a means to make that transmittable to the payer. Marty, what can we charge the patient?
Well, I think that's important, Kathy, to note that as you look at these requirements for consent, it's so narrow, and the language of the consent itself is so restrictive that there's a very clear intent in this legislation that a new set of rules emerge regarding the amount to be charged to the patient when services are provided out of network through no fault of patient themselves, these emergency situations or these out of network providers in an in-network facility. And so it's important for folks to be considering now how they're going to need to modify their revenue cycle processes to comply with these new rules. So with no further ado, how does this work? The cardinal rule is you cannot charge a patient more than their in-network cost-sharing amount when the surprise billing rules apply. So again, emergency services, and then out-of-network provider in an in-network facility. If you're in one of those scenarios, the services you provide, the amount you can charge the patient, cannot exceed their in-network cost-sharing amount. So if they had, in fact, received services from an in-network provider, they would be paying this amount. Now, of course, the issue is you're out of network. So how do you know what the patient's obligation would be if they were in network? And in fact, we know that most likely the dollar amount would vary from facility to facility because the plans have negotiated different rates with different network providers. So to solve that problem, the NSA creates this concept of the qualifying payment amount, or the new acronym, the QPA. The QPA is calculated based on the plan's 2019 median in-network rate for the same or similar services in a specific geographic area. So it is very specific to each plan, and it's going to be very specific to the service provided, and it's very specific to the geographic area in which the provider is located. Again, 2019 will be our base year, but that amount will be indexed for subsequent years, so it will continue to go up based on medical inflation. And then there are pages upon pages in the regulations that describe what we do in the case of a plan that wasn't in existence in 2019, or for services that were not reimbursed in 2019. So we'll have those rules that will help us determine what the QPA will be. This is incumbent on the plan then to provide the QPA to the provider. So that's how this process works. Is you provide the services to the out-of-network patient, you will then have information on their plan and submit the claim to the plan. In response, then, the plan is obligated to provide the QPA back to the provider, and the provider can then calculate what the patient's responsibility will be and then submit a claim to the patient for that amount. There will be no single source of truth for QPA. You can't look it up on a website because it's a median rate, meaning it is dependent on the volume of that service and the number of different providers who are furnishing that service in network for that particular plan. So it is dependent on that information loop with the plans. How this is going to work will be something we're going to learn in January and February and March of 2022, because there are no standard transactions or code sets that have been created for this form of communication between the provider and the plan for these purposes. And so we will submit the claims and we'll see how the information comes back to the provider from the plan. There are a number of requirements in the NSA, as well as its companion legislation, transparency and coverage, that apply to health plans that are all complementary and part of this price transparency movement. Many of the plan requirements, however, have been delayed, their effective dates pushed into later in 2022. But part of this, their need to respond with the QPA information to a provider claim is something they should be prepared to do commencing at the beginning of 2022. Now, the patient responsibility, we have a process for that, relatively straightforward compared to the process we will use to determine what the plan then is obligated to pay the provider for the services furnished to the patient who is out of network. And you have on your screen here, this is actually lifted from the interim final rule published in October, this back and forth between the provider and the payer. Again, this process initiates with the payer submitting to the provider their initial payment or denial of payment. So at the same time they provide the QPA to the patient, to the provider, too many P's here, to the provider, they will say, okay, we propose to pay you X for the services you provided, or we deny payment for the specified reason. Upon receipt of that communication from the plan, the provider then will determine whether they want to initiate an open negotiation period. So they'll have 30 business days following receipt to determine if they want to negotiate back and forth with the plan. And during that 30 days, they will go back and forth to determine what the payment would be. If at the end, either party is dissatisfied with the result of that negotiation, they can take it up a level and involve the independent dispute resolution process. They have 4 business days from the end of the negotiation period to initiate the IDR process by going to the federal IDR portal and inputting information. The parties can then agree, once one party initiates the process, the parties can agree to an IDR entity. They can agree this is the entity we want to resolve this matter. These entities will be approved by the agencies. They are now in the process of reviewing and accepting those applications.
And they are
Kathy
also
told me
they're also taking comments from the public on the various entities that are hoping to be approved.
If they could agree, each side's going to pay a $50 administrative fee. That is to reimburse the agencies for their cost of maintaining the federal IDR portal and their oversight of the IDR entities. And so each side pays their $50. If you can't agree between the plan and the provider, there is a process where the departments will select the IDR entity for you, and that has to be completed within 6 days following the IDR initiation date. So once we have our entities selected, each side has 10 business days to make their case to the IDR, to submit their information to the whatever they think is the appropriate and proper payment for the services provided. And the IDR then takes the ball and makes its decision, but this is baseball arbitration. They can't split the baby. They either take the amount that the payer offers or the amount the provider claims that it should receive. It has to choose one or the other. And then once that decision is made by the IDR, the losing party is responsible for paying the IDR's fees. The agencies expect the IDR fees will range between $200 and $500. And we'll see as they now select the IDR entities what those fees will be. So there's the administrative fee to start the process, and then the loser pays the IDR's fee for adjudicating the case. And then if payment is required to be made by the plan, they have to complete that within 30 days of the determination. So what we have at this point is a process. We will have to wait and see over the next several months how this is implemented, how the portal works, what information is going to be required, what happens if we miss a deadline, have we then dropped the ball on the entire process and accepted the last offer that the plan made. And clearly, this is going to be an administrative challenge. So finding the right folks in your revenue cycle department, that can take hold of this process, manage multiple deadlines, communicate appropriate information at the right time to the right people is going to be key here. Now, when the interim final rule was published in October, there was quite a blowback regarding the provisions as to the criteria our IDR entities are to apply in determining the appropriate payment amount to the provider. And that is because the agencies decided that the IDR should work from the presumption that the qualifying payment amount is the appropriate payment amount. And again, appreciate this was the agency's decision to create this presumption. This is not in the legislation. And so I assume will be the provision over which there will be the most comment to the interim final rule.
I think there are currently about 170 lawmakers who have raised questions about that and have been contacted by providers within their states and are beginning to argue against using the QPA as the payment rate.
Yeah, the agencies included in the final rule a series of issues that the IDR can consider varying away from the QPA. So the QPA is not the right weight because ... And you see here a summary of those reasons, including the provider's training, their experience, their quality, their scores on outcome measures, the market share that either the plan or the provider enjoys in the relevant geographic area, focusing specifically on the patient's acuity or the complexity of the particular item or service, demonstration of good faith efforts, either on the part of the plan or the provider to negotiate an in-network agreement during the last 4 years. But what is not relevant is either the provider's usual and customary charges or the Medicare and Medicaid payment rates. And you can bet what the agencies are doing here is balancing each side, saying, no, provider, you can't argue your usual and customary because they are, in most cases, not closely resembling reality, that those are charges that we never truly use in evaluating our services. So it's not appropriate to argue, well, you're only paying us half of our usual and customary. Can't make that argument. At the same time, the plan can't argue, well, we are paying you 150% of Medicare. Aren't you happy with that? they can't make that argument because we assume that the rates paid in Medicare and Medicaid are not appropriate for the determination of what the appropriate commercial rate should be. This is going to be certainly interesting, developing up these arguments, because the problem with the QPA is it's a median, which means half the folks are going to be unhappy with the rate and half are going to be happy with that rate because they've been paid, half have been paid less than the median, half have been paid more than the median. Just consider who's had the more dominant market power to negotiate more favorable rates. We assume that's our larger health systems. And they're the ones who are now looking at receiving significantly lower payments as a result of the QPA's presumption. This also creates really interesting issues as to how this impacts future negotiations in managed care. And that will be, we'll talk about that closer as we get to the end, as some new transparency requirements that apply to plans. And they're having to make their rates public now, come June of 2022. But this is really going to upset the apple cart. And so it's probably time to bring this attention to your managed care team, that 2022 is certainly going to be a learning experience as more of this information becomes publicly available. And now you're negotiating with each other from a position of knowledge. It's certainly going to be a big change, far beyond just the surprise billing requirements in the NSA. Kathy, anything to close out on the surprise billing piece before we move on to GFE?
Nothing from my perspective, Marty, but I would turn to Amanda or Rodney and see if there are any questions so far on the surprise billing part of the requirements.
Yes, we do have a couple of questions. The first question was someone says, I read that payers are supposed to treat patients as in-network with regard to cost share under this act. How will providers know payers are compliant with the act in this regard? And I think that goes back to the QPA and our lack of insight from the provider side of whether the QPA is calculated correctly or not. But I'd like your take on that.
Yes and no. It does go back to that, but there is a requirement in the law, although it's delayed until I believe at least July, so we should see some more regs. But there is a requirement for an advanced explanation of benefits, AEOB. You're familiar with the EOB that you get for the patient gets and that the provider gets that explains what was paid. What they're going to be issuing is an AEOB prior to services actually being provided, so that you have information from the payer, excuse me, as to the patient's out-of-pocket liability. That has been delayed for now, so you're really not going to have the information of what the patient would owe in advance without reaching out, calling the payer, I would assume.
Okay.
And I think, Kathy, although it's not specifically called out in the list of relevant considerations for the IDR entity, certainly that IDR entity process affords a provider the opportunity to challenge the plan's calculation of the QPA.
Of the QPA, yes, but in terms of what the patient would owe.
Right.
What I was looking at. And I mean, it's going to be, what would it have been if they had been in network? Remember, they do have insurance coverage. The facility is in network. So now what is the amount that they would owe the physician or the other practitioners involved in their care? And that is going to have to ultimately come through the AEOB process. But that needs to be a transaction standard.
So now there's a follow-up question to that is, how would providers know the difference between an advanced EOB or an AEOB and a payment EOB? I think we may end up posting EOBs and finding ourselves out of balance.
I think what you're ultimately going to find is that we will be developing a new transaction standard. Now, for those of you who've been around when we worked to establish the 835, the 837, you know that those didn't occur overnight. But the National Uniform Billing Committee, the National Uniform Claims Committee have discussed this to a great degree. And ultimately, there will be some sort of a transaction standard developed that will be an AEOB, and it will be clear that it is not a payment remit. Totally new standard.
Okay, another question is, you stated that no notice or consent option for providers such as anesthesia, radiology, etc. Did you mean that we should not have those patients presented with the required consent form?
They can't sign the consent. You need, they cannot be requested to consent. You cannot balance bill those patients. So Marty, I don't know if you're going to give them the form or not. What are your thoughts? Don't know why you would do it.
No, it would not be effective. I mean, they could sign the consent form, but the provider could not rely on that consent form to balance bill the patient.
And I think as soon as you did have the patient sign it, even though you never balance billed the patient might complain, and that would be a concern.
Mm-hmm.
So a follow-up question to that question is, why would we need agreements with these types of providers, anesthesia, for example?
That's to avoid the multiple notices being provided to the patient. The obligation to provide the surprise billing notice to the patient applies to the facility, but also to the providers furnishing services in the facility. And so the only way you get around having to provide that notice, if you are a hospital-based provider, is if you have the written agreement with the facility saying we can rely on your notice. That's why we want to pursue those agreements, just to not have papers and emails flying all over the place for every patient that presents at the facility. And again, that requirement applies to any insured patient. It is not limited to a patient in a circumstance where the surprise billing rules apply. It's all your insured patients with the exception of Medicare and Medicaid, well, the federal programs, because those rules don't apply there.
Okay. A couple of more questions. If a radiologist is out of network and the facility is in network, the patient doesn't have a choice as to who reads the test, would this be part of the No Surprises Act, or would it be the hospital's responsibility to advise the patient?
The radiologist would not be allowed to balance bill the patient.
Right, so it would be part of the No Surprises Act.
Right.
No matter who notifies the patient, there is no balance billing allowed
Right.
for radiology.
You could not get a consent to balance bill.
But the notice requirement, absent an agreement between the hospital and the radiologist, both the hospital and the radiologist should be delivering the notice.
What recourse does the provider have if they're unable to reach the patient prior to service? I assume that is for the notice requirements.
The notice, the obligation to deliver the notice is tied to when you first make a claim for payment. So before you ask the patient for any money, you will have had to have delivered the notice to them. So example, in the emergency department, we know when we can collect insurance information from the patient and still comply with EMTALA requirements. And so this is going to, you wouldn't change any of those existing registration processes due to the No Surprises Act. It's simply you're going to add the NSA notice to that collection of papers we provide to people, right? So we get into the notice of privacy practices, the consent to treatment, all of those notices that are provided, we'd include the NSA surprise billing notice as part of that.
And one
But-
thing, oh, go ahead, Marty.
Go ahead. No, go ahead. Go ahead.
I was just, because you made me think of something when you said that. One thing to remember, folks, is under the requirements under the No Surprises Act, if you actually do have a patient who agrees to be balance billed, let's think from the surgeon perspective, you must give that waiver or the consent to the patient to be balance billed. At the same time, they are signing their consent for treatment. It cannot be given to them with any other items other than the consent for treatment. So if you would routinely be giving the patient the consent for treatment and some additional prescriptions and some other items that you might be doing, follow-up instructions, etc., all you can give the patient is the consent for treatment and the consent to be balance billed. The others would have to be given at a different time.
And while we're talking about forms and signatures and the like, note that the delivery of the NSA surprise billing notice does not have an acknowledgement requirement attached to it. So you don't have to capture a signature that I received a copy of your NSA surprise billing notice, but you will certainly want to make sure you have a process in place that you can demonstrate compliance with having delivered the notice. But you're not going to have to add, yet another signature, at least per the regulations. You may choose to do that as a vehicle to demonstrate your compliance with the requirement, but it is not a specific regulatory requirement. That's different than what we have, with the notice of privacy practices. You have to receive the acknowledgement, but that's not how the NSA surprise billing notice works.
Right. Couple more questions, not related to the good faith estimates that we're about to get into. Tennessee currently has an out-of-network acknowledgement form where providers are required to provide notice of to patients for hospital-based providers and who they are billing. That does not state whether they are in network or not, although it can. Would this replace that requirement is the question.
I'd have to take a closer look at the actual regulatory requirement, because there's a relatively consistent theme throughout the NSA that these rules are to be supplementary to state law as opposed to replacing or displacing existing state law.
Right.
And it's just going to depend on the specific wording of that regulation.
It might, if it's something that is confusing or awkward in terms of the new requirements, federal requirements, it might be something to both for the THA and TMA to look at perhaps having that removed from current state requirements.
Okay. I think this is simply a notice of who they may receive care from. There's no balance billing or anything associated with billing, so I'm not sure that that the federal regulations for No Surprises Act would override that. Would a paper notice need to be provided to the patient at every visit or only once is one of the questions.
Yeah, it's just not altogether clear from the regulatory text. Again, I always keep comparing this to HIPAA. It is very clear in HIPAA, you only have to provide the notice once. It's explicit. There's no similar explicit language in the NSA regulations. And so it appears that this would be a notice you provide on an ongoing basis. However, that may be a reason that you want to capture an acknowledgement So you wouldn't have to provide it every single time that the patient receives a service at the facility. And again, we're going to get into good faith estimate because we're out to confuse you as best we can here. The notice requirement under GFE works very differently. But the notice requirement under NSA is when services are delivered at a facility. So there's not going to be a notice, a NSA surprise billing notice provided in the physician clinics. It's only going to be in those facilities where the notice is provided. What creates some administrative headaches for the fact that when that notice is required, it's coming not only from the facility, but from the providers who are delivering services to the patient at the facility.
All right. What if a ER patient is served a consent and the physician does not determine it as an emergency or vice versa? How do you think the triage can work side by side with the consent process?
The patient is in the emergency room. I don't think you're going to be giving them, talking to them. You've got to have your attending physician make a determination that the emergency is ended before this could ever happen.
So you
And
couldn't,
an emergency room physician can never get consent.
Right.
right. You couldn't issue the consent before an emergency was over, right?
Well, and don't forget, the emergency room physician can't get a consent.
Right. Okay. One more, and this is as it relates to denials. So do we foresee greater administrative burden for providers in responding to denials? For example, payer denies based on a possible to treat at an in-network facility. Will the provider be required to seek physician documentation or statements to support the need to have kept the patient at the out-of-network facility?
I'm going to take a stab at that and begin with the fact with the emergency, and the patient went to the emergency room, whether that emergency room was in network or out, or whether the facility was in network or not. What is your documentation of the reason that the patient presented, the patient's presenting symptoms? And again, we're applying prudent layperson. Now, in the case of a patient who, in a non-emergent situation, Marty, correct me if I'm wrong, but one of the things that you are going to have to, while you're in the process of getting consent to balance bill for those physicians who can, I believe ultimately there is a requirement, and I can't remember right off if it was a requirement from the physician or the provider, well, the physician, or if it was a requirement of the plan, but the patient is going to have to be told of providers who could do this service in network.
That's a plan requirement.
Okay, it's a plan requirement.
And it wouldn't apply in an emergency.
Not in an emergency situation, right? But in a non-emergent situation, in the emergent situation, it's the documentation to support the emergency service. But in the case of a non-emergent service, patient has got to be given information related to providers who could do that service in network.
Mm-hmm. But it's a delayed plan requirement.
Yeah.
Okay. Let's go into good faith estimates and see if we can answer some of the questions that have already been submitted on that one.
Well, why don't we go through that part of the presentation and then we'll hit those questions.
Absolutely.
Yep. So remember what I said at the beginning, you've got to think of these two as separate regulatory requirements. Because if you start mishmashing them, and goodness knows, Kathy and I have gone through mishmashing them and unmishmashing them several times, but you'll lose the specificity of the regulatory requirements. So we've been talking about insured patients receiving services from out-of-network providers. Now we're talking about self-pay patients, and the obligation on providers to deliver a good faith estimate either in response to a patient who is shopping for services or the actual scheduling of a service by a provider. So that's the realm we're in today. From the top, we start with the concept of who is the convening provider. And the convening provider would be the provider responsible for scheduling the primary item or service. That's going to include office visits, diagnostic testing, and procedures. So we are not just in the realm of facility now. Now we're talking about services that are delivered in the physician's offices and are scheduled, like an office visit is scheduled. So you're going to be required to provide a good faith estimate of total expected charges when a self-pay patient requests an estimate. So they are comparison shopping. They're not ready to schedule, but I need to have XYZ procedure performed. I'm going to call this physician's office and ask what they would charge for that. That's magic language that would trigger that provider's obligation to provide the good faith estimate. The other instant when the GFE is triggered is when a self-pay patient schedules an item or service at least 3 business days in advance. This rule does not apply for next day schedules, for example, because there's recognition there would not be sufficient time to formulate the GFE in those circumstances. The good faith estimate provided to the patient must include all items or services to be billed by the convening provider. So for example, if it's the hospital that's scheduling the procedure, the hospital is going to include in the GFE those professional fees for which the hospital bills. But it would not be responsible, at least for now, for including those for which it does not bill. Starting in 2023, the convening provider will be required to include in the good faith estimate those items and services to be billed by co-providers, defined as those who furnish cares in conjunction with the primary item or service. So again, if you're scheduling a procedure, this is the charges by the radiologist, the anesthesiologist, the pathologist. Those would all be rolled into the convening provider's good faith estimate, starting in 2023. So you can breathe again. You've got a year on this part of it. The obligation then on the co-providers will be to respond to a request from a convening provider to furnish the information necessary to complete a GFE within 1 business day. So again, hospital schedules the procedure, has to submit the GFE to the patient. They will notify the anesthesiologist, the radiologist, the pathologist saying, we need your information to complete this GFE for this patient. 1 business day to turn that around and get it back to the hospital. Again, the requirement for the convening provider to include the co-provider information on the GFE is delayed until January 1st, 2023. So for 2022, we are creating GFEs that only include those services for which the convening provider bills. This creates an interesting issue with how services are scheduled at facilities. That in some instances, the physician actually does the scheduling at his or her office for a procedure to be performed at, for example, an ambulatory surgery center, versus the physician telling the patient to call the ambulatory surgery center and schedule the procedure. In the latter case, if the patient calls the ambulatory surgery center to schedule, then it's clear that the AFC is going to have the obligation as the convening provider, and it will provide a GFE to the patient that includes the ASC's charges. Where it gets more confusing is when that scheduling is actually done from the physician's office. And so there'll have to be some figuring it out in the next year of whether the physician's going to provide the GFE, including the physician's charges and not the ASC's charges, in a circumstance where the scheduling is done from the physician's office. It's just, it is not addressed in the regulations because the regulations assume that these GFEs are going to include both the convening provider and the co-provider, but then the agencies come back and say, we, in our enforcement discretion, will not require the GFEs to include co-provider information until 2023. And so we don't have a regulatory solution to that issue of when a procedure is scheduled at one location to be performed at another. And so our advice at this point is to communicate between the facility and the physician office and determine who's going to assume the responsibility for the GFE.
And Marty, one thing that I'll just mention before we go on to the process, but recognize this is Marty has it on her second bullet. This also includes those services that a physician is scheduling in his office. That if the individual is self-pay, you're going to have to give them this estimate if they're scheduling more than 3 business days out.
And what we're also seeing folks ask a lot of questions is around this issue of request, because the obligation to provide a good faith estimate attaches when a self-pay patient requests an estimate. They're not ready to schedule, but they request an estimate. So in response to that request, you provide the GFE. It also attaches when a self-pay patient schedules an item or service. The fact that the patient doesn't ever request the GFE is irrelevant. It's the fact they schedule triggers the requirement to provide the GFE. So you're not waiting on a request from a patient for a GFE when you're actually in fact scheduling the procedure. It's the act of scheduling that creates the obligation to provide the GFE by the convening provider. So step by step.
Let me go through this. And Marty had to train me. She's done an okay job, but we'll see. The first thing that we have to look at, and we have to focus on the term self-pay. It is not just an uninsured individual. I have to say that I was frequently using the term uninsured, but it is going to apply, of course, to those who do not have insurance coverage. It is also going to apply to those individuals who have insurance coverage but don't intend to submit a claim for the service for some reason. The item or service that they are having provided is not covered by their insurance. They become self-pay, but you also run into the instance of the individual who has insurance, but that insurance will not pay for out-of-network services. So recognize that it's not just uninsured individuals, but it is also certain individuals who have insurance, but the provider is not billing the insurance. Next slide. Let's talk about the notice. Okay, first of all, when you are scheduling or when the patient is asking questions about the cost of care, you're going to have to inform them that a good faith estimate is available. You're also going to have to post that GFE on your website and in a physical location within your facility. We're just going to continue to attack the walls. We're going to say right next to the HIPAA privacy notice and the notice that you just posted related to surprise billing, we're going to have you also post the estimate that you see on this screen that is the good faith estimate notice telling them that they do have the opportunity to get a good faith estimate. Even though you're telling them that they have the opportunity, recognize that you must give it to them upon scheduling. Next slide.
Hey, Kathy,
Oh,
just to
yeah.
note, see that on the model notice, see the insert phone number? That's the same phone number that was on the prior notice that you would use here. So just, I forgot to include that here when I updated the slides. Okay.
This just gives you an idea of the template that is to be used for the good faith estimate. Very detailed in terms of the information that's required because it is specific to the patient, patient's name, patient's date of birth, address information, diagnostic information. And you can see in preparation for providing information on multiple providers, you've got the provider's name, total estimated cost, second provider, et cetera, so that you do have a series of providers that could be accommodated on this once we get to 2023 with the convening provider having to provide information related to the co-providers. If you'll notice right under total estimated cost, the following is a detailed list of expected charges for whatever the service was scheduled for a particular date. And then you need to list the services that are recurring, if this is going to go on, if you could make this usable for 12 months. But it does get into a certain degree of detail in terms of the expected charges. I have not seen anything that truly defines everything to be included in that detail. Is it the office visit? Is it medical supplies? What are they really looking for here? We have seen where they call for information related to diagnostic codes, CPT codes, things like that. But I am not sure, I don't know, Marty, if you are, as to how detailed they really want this to be.
Just to note, Kathy, that this is the first page of the first 2 pages of what's
Right.
a 7-page template.
Exactly. So I think you're getting into a lot of detail. Now, one thing that I have just picked up recently about this GFE, it does need to become a part of your medical record. So whether this is some way or other, it becomes a part of your electronic record or your paper record, but you're giving the GFE to the patient, but you're also retaining a copy of it in your patient record. So recognize that that becomes a requirement. Go on to the next slide, Marty. Related to, again, the written GFE. It does have to be that total dollar amount that you're giving them has to be inclusive of any applicable discounts. If you are perhaps reducing your charges by 25%, then that needs to be reflected on that GFE. And if, for instance, you know that there is going to be an evaluation and management service provided, but there's a range of services, you need to give them the range of the charges that could appear. You don't just pick one and go for the average, anything like that, or assume it'll be a level 2 when it could wind up being a level 3 or 4. So you should give them a range. Now, we talked about with the consent or the waiver to be balanced billed, the timing that was involved there. Well, we've got timing here as well. And you got to be careful that you don't confuse the two. Okay, but let's talk about timing for the good faith estimate. If it is requested prior to scheduling, then you have 3 days following the request to give the patient the information. If the service is scheduled at least 10 days, but less than 4 business days in advance, then you're going to have to give them the estimate, the good faith estimate, at least 3 days prior to the service being rendered. If it is scheduled at least 3 business days in advance, then you're providing this estimate to them 1 day before. The note about recurring services, if you have a patient who is coming in for, let's say, physical therapy, and this is going to run for a period of 3 months, then you can give them the estimate one time with the detail of the information that is being provided and the duration of the time for this service. However, it can never run for greater than a 12-month period. There is a limitation on that under the requirements of the rule. So Marty, can you jump back once, I believe, to actually 2 slides? I want to call something to their attention. Under this, you have a right to receive a good faith estimate. If you look at that next to the last bullet, if you receive a bill that is at least $400 more than your good faith estimate, you can dispute the bill. $400 in a physician's office might not, you might not get into that situation very often, depending upon the services that are being provided or if there's a procedure involved. But in a hospital, definitely it could be greater than $400. So Marty, do you want to talk about the dispute resolution there?
So we already talked about the independent dispute resolution entity that resolves differences between plan and provider. We will also have selected dispute resolution entities, the SDRs, that will handle complaints by individuals regarding the good faith estimates they received. As Kathy noted, the self-pay patient who is billed at least $400 more than the amount listed on the GFE can initiate this dispute resolution process within 120 days of receiving the bill. Again, they'll use an online portal to accomplish that. They will pay a $25 administrative fee. That amount will be adjusted annually. Upon receipt of that request from a patient, HHS submits the matter to one of its selected dispute resolution entities. The SDR then notifies the provider that the issue has been presented, who will then have 10 days to respond with credible evidence supporting the higher billed charges. The SDR then reviews that information submitted by the provider, determines if there is no credible evidence to support the higher charge. The provider is bound by the amount listed in the good faith estimate. If there is credible evidence, i.e. there is no way we could have foreseen that the patient would have needed this additional service and we had to bill for it, for example, then the SDR will apply either the billed charges or the median payment amount paid by a plan or issuer of the same or similar service by the same or similar provider in a geographic area reflected in a to-be created independent database. So this will, in effect, create an effective charge for self-pay patients, because if the patient challenges your estimate because it's more than $400 off the mark of what they actually received, and they appeal to this SDR process, the SDR is going to eventually require an adjustment to the bill if that bill is higher than what the amounts listed in this independent database would be. So back to that, oh, we could not have foreseen it, so we had to provide this service. If that's the basis of the challenge, and the SDR agrees with you, yes, could not have foreseen that, absolutely, understand why it was not listed in the good faith estimate. But they're not going to allow the charge listed on the bill if it is higher than the amount listed in the independent database. So that's going to begin much broader implications of these processes established by the No Surprises Act than the actual resolution of independent claims. this really raises the issue of how do we price services for self-pay patients, appreciating we've got this SDR entity out there who will adjudicate these claims if the issue is initiated by the patient. So appreciate that. We don't have details yet on the independent database. Certainly, the agencies are in the process of standing that up, just like they're in the process now of standing up the IDR and the SDR entities themselves. So before we get to questions, what are our recommendations on what to do over the next month besides complete your Christmas shopping list? Let's break this into what you need to do on the surprise billing side, what you need to do on the good faith estimate side. For surprise billing, compliance with the notice requirements, again, for facilities, getting written agreements with your providers who furnish services in the facility so that you avoid the multiple notices. A process to identify services that are subject to surprise billing, again, the out-of-network emergency services, out-of-network non-emergency services furnished at an in-network facility. So being able to segregate those claims so that then you will be in a position to follow the rules as you start seeking payment for those claims, either from the patient or negotiating process with the plan itself. Remember again, because I don't want you to confuse the two requirements, surprise billing doesn't apply to physicians not providing services at facilities. So this is not the worry at the physician practice today. It would be if you provide services in the hospital, then yes, you've got the issue of providing the notice to the patients at the facility. But in the physician practice itself, it does not apply. On the good faith estimate side, it's this process of identifying who are self-pay patients, both when they make inquiries as well as when services are being scheduled. Again, compliance with the notice requirements, a top priority, both the website, the physical locations, and handling the inquiries and scheduling. And then assigning a individual responsibility for completing and sending GFEs in a timely manner. Making sure you've got an individual in your organization who's familiar with these rules, is familiar with the templates, has access to the data necessary to complete the GFE for the convening provider. Again, remembering for 2022, we're not in a position of having to include the co-provider on the GFE for now. So it's a doable list, we hope. I mean, certainly in Q1 of 2022, there'll be a lot of lessons to learn. A lot we'll learn from each other as we go through these processes in applying these rules. But to get to go, these are the particular items we think you should be focused on at this point. Now I want to stop. We've got 7 minutes left. We have some more content that talks about the transparency and coverage rules, but I want to make sure we answer any of the specific questions on GFE first.
Yes, just a couple of questions on GFEs. Are all the fields required on the good faith estimate? And the second question there is, not sure that the patient will know their own diagnosis codes if they're shopping.
You would complete the form to the best of your ability. Again, it's a template. It's not mandatory that you use the template, but the template reflects the regulatory language. And again, don't lose faith. Don't lose sight of the first two words, good faith. So if you have the information available to you, include it on the form. If it isn't available, then you can't include it.
Well, and in terms of the patient coming in, let's say the patient is going to have a colonoscopy and is self-pay. You might not have a diagnosis code per se, but you might have a procedure code. It might not be the ultimate procedure code, but you could even provide a range there.
Right, very good. Has the government provided a phone number to insert on the good faith estimate form that we must provide patients? I didn't see it listed on slide 17 and haven't found it on the CMS website yet.
It took me until, I've been looking, and it took me until today to find it. It is, I'm sorry if everyone's getting dizzy here. There's your number right there. And they have said it was a memo issued by CMS on October 25, but I never saw it. And trust me, I've been checking out the CMS website pretty regularly, but they say in the notice that they published on October 25 that this number, if you call it today, and I was going to, but I didn't before the webinar, but if you call it today, it's a pre-recorded message saying this will go live on January 1st. And presumably, the agencies are now coordinating to stand up a call center that will live behind this number. Okay, close your eyes, everyone. I'm going to go back to the other slide.
Would surprise billing apply to physicians in hospital-based clinics?
Yes. Absolutely. Because you're providing services with, and assuming that it is an in-network clinic, in-network to the hospital, it is a hospital outpatient department.
Right. Okay, one more question, unless something comes in while we're answering this one. And it refers to the most common 15 languages. What's the recommendation for providing the good faith estimate in the most common 15 languages? I haven't seen that CMS has translated any of these documents, so I assume it is left up to hospitals to translate for themselves in the languages that they would need.
Yes, within your community, and that applies to not only the good faith estimate, but also to the information about the patient protections against balance billing. All of those need to be made available in the 15 most common languages within your market, within your community, and you also need to make accommodations for deaf, sight impaired, etc.
These are HHS Office of Civil Rights requirements that apply across the board to all required notices. So it's just the same rules you're following today for HIPAA notices are the same you're going to apply to these NSA notices.
Perfect. That is all the questions. Ladies, I will leave it up to you if you want to try to go through some of this other material that you had, if you want to just kind of breeze through that.
Real quickly, because there's nothing better after beating you down with new requirements that are applicable to providers to tell you about new requirements that are applicable to plans. Hopefully it will make you feel a little better. But there are certain requirements on plans that are part of the No Surprises Act, but there are others that are in this companion legislation, transparency and coverage. And then there were regulations that CMS was already in the process of promulgating even before the transparency and coverage rules. So real quickly, because these are going to impact your ability to meet your NSA requirements, we'll walk through these. Starting with continuity and coverage, that if a plan discontinues a facility or provider as part of a network, it is still required to provide coverage for 90 days for patients who fall into one of these 5 categories. The idea is you don't want interruption in coverage that could negatively impact outcomes. However, there are no implementing regulations for this requirement that are going to be published before January 1, but the agencies impose a good faith obligation on the plans to comply with this requirement. So if you have patients, if you find yourself, you're going to go out of network because of a termination of a contract, appreciate that patients in one of these 5 categories, you will continue to have coverage for them. Second is provider directories. Health plans are required to maintain current provider directories, having a verification process to ensure they are accurate, protocol for responding to individuals who inquire about a particular provider's network status, as well as providing a publicly available database listing providers that are in network. Again, no implementing regulations, so a good faith compliance required by plans. The agency has also noted that a plan is deemed to comply with this requirement so long as it does not penalize a patient who relied on inaccurate information. So if you have an out-of-date directory, someone goes to that provider, they cannot claim that's then an out-of-network provider to them. Third are the notification requirements that The plan must post on their website and include in plan communications similar notices regarding balanced billing protections. But unlike providers that got very specific regulations on what those notices will look like, providers' plans do not, but they still are required to comply based on a good faith interpretation of the regulation. And then specifically on transparency and coverage. By January 1st, plans are required to issue ID cards that list applicable deductibles, applicable out-of-pocket maximums, and a phone number and website for individuals seeking assistance with regard to their patient responsibilities. So hopefully, as we are all finishing up open enrollment and those plan cards are mailed out, they're going to have this higher level of detail, which will certainly be helpful to providers as they address these issues with out-of-network patients. By July 1, 2022, plans must disclose on public websites in-network provider rates for covered items and services and out-of-network allowed amounts and bill charges for covered items and services in machine-readable formats. So that is plan transparency. And as we referenced earlier, it certainly reshuffles the cards in terms of ongoing managed care contract negotiations. Then finally, by January 1st of 2023, plans will be required to post a self-service price comparison tool to assist individuals in determining cost-sharing liability. So provider A versus provider B, how much will I owe? Having that information available on that price comparison tool on the plan website. So certainly a reason to stay tuned in terms of what the agencies publish in regulations here in the immediate future. Certainly we have July 1 circled on our calendar as we will take a deeper dive and learn about plan charges. You know, these plan rates that have been so carefully guarded state secrets. Now in about 7 months, will all be posted publicly. So certainly a new era in terms of provider and plan relationships. And also consider that as you're contemplating, you know, how you present evidence in your IDR or how you potentially may question a QPA having this data available. So again, very quick rundown of what's coming in the near future. We appreciate you, souls who have stayed with us for an hour and a half on this. You have at the very beginning, Kathy and my email address. Don't hesitate to send us a question. We do our best to get to them. We weren't real great over Thanksgiving week, but we're back in the saddle and ready to go. Kathy, anything else?
No, just want to thank everybody for their time this afternoon.
Yeah, and Marty and Kathy, thank you guys again for what a thorough and thoughtful overview of the No Surprises Act. So as we close today's webinar, I also want to thank TMA for partnering with us on this, and we will be sending out an email with a link to view this recording, as well as a link to download the slides used in today's presentation. So thank you all for attending, and I hope you all have a great afternoon. Thank you.